All right. So it's a real honor to be invited back for a second year in a row. It's been a great conference, and again, really appreciate the invitation. So I'll be discussing the contemporary approach to medical therapy for heart failure. So let's start the conversation this morning by first putting the risk that heart failure carries in context. Now, we're so used to, throughout all these different fields of medicine, hearing about things that are called high risk. You almost get numb to it, hearing about every different medical condition, subspecialty has their own high risk version. But important to understand that not all high risk conditions are created equal. It's important to anchor that relative, that subjective term, high risk, with the actual absolute risks of bad things happening. And conveniently within cardiology, we have the cholesterol guidelines, which for some time traditionally we're using the pooled cohorts equation. You type in some factors, you get a 10-year risk of ASCVD or stroke, and you can annualize that risk. And then also the cholesterol guidelines, we're using terminologies like intermediate risk, high risk, and even the most recent iteration has a term very high risk. So when you look at those, the cholesterol guidelines would say someone would be high risk if they had about a 2 to 5% per year risk of heart attack or stroke. And they even have the terminology very high risk, and look at the real world evidence, people that meet those criteria have about a 5 to 8% per year risk of heart attack or stroke. Now, I certainly would agree, very high risk, 5 to 8%. Wouldn't want it to be my own risk of heart attack or stroke. Seems like very high risk to me. But the important takeaway here is if we're going to call 5 to 8% per year very high risk, what on earth are we going to call our heart failure patients? Even our lowest risk heart failure patient, the patient who comes to your office, no complaints, NYHA class 2, never, ever been hospitalized. They have a 1-year risk of CV death or heart failure hospitalization of 10% per year. We can't get risk in heart failure lower than that. And then when you have our run-of-the-mill patient who's been hospitalized for heart failure, worsening heart failure events, they're talking about a 1-year risk of 40% for CV death or heart failure hospitalization. So again, if we're going to use terminologies like high risk, very high risk, or all these different fields of medicine, heart failure is truly an extreme high risk or even very extreme high risk condition. But we have this very extreme high risk condition. What's our approach to treatment? Well, paradoxically, it's one where the status quo is we take our time. We do one move at a time. There's no rush to get people on treatment. And something like this is something you might see in clinical practice. Patient, new diagnosis of heart failure with reduced ejection fraction. Start them on an ACE inhibitor. Maybe you start them on a beta blocker at the same time. But either way, you might wait a few weeks, make sure they're tolerating the doses, up titrate, sure a few more weeks, up titrate the dose further. Then after it's been a couple of months, you're like, okay, well now it's time to get spironolactone started. We start that therapy, wait a few more weeks, check the potassium, ensure tolerability, up titrate the dose. Then you say, oh, well, sacubitril valsartan is superior to ACE inhibitors. So let's stop the ACE inhibitor. Let's do a washout. Let's switch to sacubitril valsartan. Let's wait a few more weeks, though, ensure tolerability, then up titrate. And then after that, you're like, okay, well, now it's time to get them on quadruple therapy. Let's start them on an SGLT2 inhibitor. And while very well intentioned, this one move at a time, serial, slow, selective approach can take 28 to 56 weeks before a patient is at maximally tolerated or optimized doses of GDMT. And again, remember, we're dealing with a very extreme high-risk condition, and this is how long it could take if everything goes perfect for getting them on therapy. But needless to say, while they're on this long circuitous pathway to optimized quadruple medical therapy, lots of things get in our way of success. Patient gets hospitalized. Patient misses a clinic visit. Maybe you're in a busy clinic and you're rushed and you're like, I don't have time to talk about a new medicine. They're doing fine today. Let's just let it ride and kick the can down the road. But needless to say, while the patient is on this long circuitous pathway, they are needlessly exposed to excess risk of death and worsening heart failure the entire time. And what does this status quo serial and selective approach get us? Well, it gets us what we saw in the CHAMP-HF registry. And this was published a couple of years ago. This is outpatient U.S. clinical practice, heart failure with reduced ejection fraction. We see there's minimal initiation and titration of GDMT in U.S. practice over time. Patients come back clinic visit after clinic visit, median blood pressure 120, median eGFR greater than 60, strongly suggesting there's more than enough room to make changes and escalate GDMT if we were paying attention. But again, the real-world evidence consistently show that we seem to be falling asleep at the wheel. And even for our patients that are hospitalized for heart failure, they obviously were failing whatever therapy they were on before the hospitalization. They come in with worsening heart failure. There's minimal initiation and titration of GDMT during these hospitalizations. These are real-world evidence from North America, both the United States and Canada, and the Victoria Registry. What we have here is a diurese and discharge mentality. Patients come in on sub-target or no medication at all for particular GDMTs. They leave on sub-target doses or no medication at all for GDMTs. Very little medication initiation and titration. And it all culminates in the Victoria Registry at time of discharge, where you have people walking out of the hospital with a median blood pressure 110 to 120, median eGFR 50 to 60, strongly suggesting that we had more than enough room to escalate GDMT if we were paying attention. Yet what we see is that 1 out of every 3 not going home on any dose of ACE/ARB/ARNI, 1 out of 4 not going home on any dose of beta blocker, and more than half going home on no dose of MRA. And not only when we're sending patients home without these GDMTs, whether it's from the clinic or the hospital, not only are we needlessly exposing them to excess clinical risk of death and worsening heart failure, the real-world evidence would also say that when you kick the can down the road, you're also unfortunately destining that patient to never getting the GDMT at all, or at best, only after substantial delay. These are data from the Get With the Guidelines Heart Failure Registry. These are U.S. patients hospitalized for heart failure in the United States. It shows what happens if at time of discharge, you have an eligible patient for GDMT, and you decide to prescribe, or you say, well, I know they're eligible, but not my job. Diurese and discharge, they'll follow up with the outpatient clinician. If you kick the can down the road, that eligible patient, just looking at ARNI and MRA, for example, has more than a 75% chance they will not receive that medication over an entire 1 year after they leave the hospital. What you do at time of discharge sticks. And again, we're very well-intentioned. We have a lot of trust in the outpatient colleagues. But again, we're well-intentioned, but the real-world evidence consistently shows when you kick the can down the road, patients don't get the therapy. So to combat what I would call an overwhelming culture of clinical inertia, myself and colleagues back in 2021 proposed the concept of simultaneous or rapid sequence initiation of quadruple medical therapy for heart failure. The key concept being to start all 4 mortality-reducing drugs for HFrEF without delay on day 1, or in rapid sequence within a maximal of 1 week. And the key caveat here is that we initially focus on the very low doses of these medications. So we're talking about sacubitril, valsartan 24-26, beta blockers like carvedilol 3.125, spironolactone 12.5. There's only 1 dose of SGLT2 inhibitor. And after patients are on at least a sprinkle of all 4 therapies, then we focus on up-titrating them over the subsequent days to weeks. And then the subsequent year, we had the U.S. heart failure guidelines get published, which the key headline in the HFrEF section was, of course, well, we now have 4 pillars. So, we have the SGLT2 inhibitor as the newest addition. But not only did these guidelines say what we should be doing, they also said the tempo with which we should be doing it. And they actually comment that these step 1 4-pillar therapies may be started simultaneously and without getting distracted with specific medication sequence. But the important concept is they should not be delayed in our eligible patients. So now you might be saying, well, okay, well, sounds great, but what's the evidence for why this is the best thing to do? And the foundation for understanding why simultaneous or rapid sequence initiation of 4-pillar therapy is so important is to recognize that it doesn't take months or years on these drugs for the clinical benefits to show up, but just within days to weeks of starting these drugs, you see very early separation of event curves. You see that's for all 4 of the pillars, such that you can appreciate that when you delay initiation of any of these 4 therapies, even a couple weeks, it's needless exposure to excess clinical risk. And then when you also recall them, we're talking about a very extreme high-risk condition. recognize that these four pillars are fully additive in their benefits. We need to give that very extreme high-risk condition all the help it can get and leverage, again, the fully additive benefits of all four of these therapies. But it's not just about efficacy. It's also about safety and tolerability. And while a lot in the audience might be thinking, well, gosh, starting all these medicines at the same time or in short order might worsen tolerability, there's actually data to suggest the drugs work well together and might actually improve tolerability. Take, for example, SGLT2 inhibitors. Conveniently, they decrease the risk of hyperkalemia. They slow the progression of kidney disease. Likewise, sacubitril/valsartan compared with an ACE inhibitor decreases the risk of hyperkalemia on an MRA. But it's not just benefits, for example, on serum potassium or eGFR, not just the lab value benefits. This also might equate to less MRA discontinuation. And from the real world evidence, we know that MRA, it's cheap as dirt, yes, horribly underutilized, needs all the help we can get for a real world implementation. And we have here data from Emperor Reduced, for example, on the left-hand side. Among patients on MRA at baseline, if you got randomized to empagliflozin, you had a 22% lower likelihood of discontinuing MRA. Likewise, sacubitril/valsartan compared to enalapril in the Paradigm-HF trial, statistically and clinically significantly less MRA discontinuation. So putting these data for like the serum potassium and then the MRA discontinuation rates together, I think it's very reasonable to consider that delaying initiation of an SGLT2 inhibitor or delaying that switch from an ACE to an ARNI, that exposes your patient to excess risk of hyperkalemia and ultimately MRA discontinuation. But again, I know there'll be hesitation with this approach. And this comes up all the time when I get all the questions. They're like, gosh, how can we possibly start more than one medicine at the same time? How can we possibly do this? And I will say, first and foremost, there is no objective evidence that simultaneous or rapid sequence initiation increases the risk of medication intolerance. Absolutely no risk of that. That's objective evidence whatsoever. But a couple of key comments for context. One is that recognize that tolerability is enhanced by initiating low doses at the onset, already discussed. That's extremely important. Two is that two of the four pillars, SGLT2 inhibitor and MRA, rarely cause symptomatic side effects in and of themselves. And then three, to recognize that HFrEF disease progression can be misinterpreted as medication-related adverse events, and that this disease state worsening is much more likely if you delay any of the four pillars. Well, what do I mean by this? On the right-hand side, see data from Emperor Reduced with empagliflozin and HFrEF. The odds of the patient's NYHA class getting better or getting worse go in completely different directions within 4 weeks, whether the patient gets randomized to empagliflozin or placebo. So put this in a clinical context. Have a patient in your clinic today. They have no complaints. They're feeling fine. You're in a rush. You say, okay, let's just let it ride with whatever therapy they're already on. They're eligible for SGLT2 inhibitor, but you defer. You essentially are, by withholding SGLT2 inhibitor, indirectly increasing the chance that 4 weeks from now, they're going to come back with the worsening NYHA class. And then when they come back, now you're on the slippery slope of asking yourself, well, gosh, maybe this fatigue and dyspnea, maybe this is related to the beta blocker they're on or the ACE inhibitor they're on. And then you're on this downward spiral of blaming the GDMT and withdrawing GDMT, when in fact, this entire situation could have potentially been prevented at 4 weeks in the past when the patient was eligible in your office with no complaints. You started an SGLT2 inhibitor. It's the same with the other GDMTs. But also when people come to me, well, how can you start all these medications at the same time? Let's just take a step back and think about what do we do for the average patient with STEMI, with LV dysfunction? A patient be walking down the street, no medical history whatsoever. They have their STEMI, they get rushed to the cath lab, we get their PCI. We think nothing of it over an average length of stay of starting that patient on multiple medicines, right in short order: aspirin, P2Y12 inhibitor, statin, ACE inhibitor, beta blocker, MRA if they have low ejection fraction. It's the culture of care. Yet the patient hospitalized for worsening heart failure, despite on average that worsening heart failure patient being extremely high risk compared to the average STEMI patient, we follow a diurese and discharge mentality where there's very few, if any, escalations in life-prolonging therapy. It's a culture of care. But then others will say, well, this is especially before the strong HF trial, which I'll talk about in just a couple slides. But Steve, okay, fine, we get your point. But There's no dedicated RCT of starting more than one medicine at the same time in heart failure. So how do you actually know that this is safe and that this works? And, before the STRONG-HF trial, I would say, well, sure, there had been no RCT, but there's absolutely no evidence that delaying initiation of any pillar of quad therapy accomplishes anything beneficial, and no evidence that it improves tolerability. And instead, there is evidence that when you delay initiation of a pillar of quad therapy in an eligible patient, you're needlessly exposing your patient to excess risk of death and worsening heart failure. And also, again, the important reality that when you kick the can down the road, they oftentimes don't get that medication at all, or at best after a substantial delay. But then in 2022, we had the publication of the STRONG-HF trial. So now it's like the icing on the cake, the cherry on top for the argument of simultaneous rapid sequence optimization of GDMT. STRONG-HF was an international trial of patients hospitalized for heart failure that were initially on suboptimal GDMT. Half the patients prior to discharge were randomized to rapid sequence simultaneous in-hospital initiation of GDMT with close follow-up, versus the other half of patients got usual care and were discharged in what they normally would. As you might expect, there was tremendous differences in the levels of GDMT each one of these randomized groups were exposed to. And what did that major difference in GDMT exposure buy us? It bought us an overwhelmingly positive clinical trial. Looking for the primary endpoint, 180-day readmission for heart failure, all-cause death, 34% relative risk reduction with rapid sequence, high-intensity GDMT. This 34% relative risk reduction equated to an enormous absolute risk reduction of 8.1%, number needed to treat to prevent a death or heart failure hospitalization over 6 months of only 12. But it wasn't just about the hard clinical outcomes. The patients also felt better with high-intensity GDMT compared to usual care. There was improvements in NYHA class, incremental lowering of NT-proBNP over follow-up. And then for those that were so worried about the safety and tolerability of high-intensity rapid sequence GDMT versus usual care, no significant difference in serious adverse events. But still, there will be hesitation. They're going to say, well, sounds great, and these clinical trials are great, but my patients that I see in my practice are too old, they're too frail, they wouldn't be in the GDMT trials, so it doesn't apply. And the first thing I say to these people is, well, show me the evidence that for that patient, assuming they don't have an absolute contraindication, show me the evidence that withholding GDMT from that patient is going to be helpful. Just show me that evidence, and they can't answer me. But then I'll say, the other thing to realize is that we should take comfort that a lot of patients like your patient in clinic were in these trials, believe it or not. And guess what we see? Regardless of age, including among the subset of patients that are older, above the age of 75 or 85, consistent benefit of the 4 pillars in HFrEF. What about frailty? This is just one example with SGLT2 inhibitors, that consistent relative risk reduction across the entire spectrum of frailty, consistent safety as well. But important to recognize that a lot of the patients we're most hesitant to treat, like frailty, for example, they have higher baseline risk by virtue of being frail. So that same relative risk reduction, which I said is consistent on the left-hand panel, that same relative risk reduction equates to even larger absolute risk reduction among the frail, for example. Lower number needed to treat. That frail patient, by these data, has more to lose in terms of absolute risk reduction when we withhold therapy. And then what about for these older and frailer patients? Well, people say, oh, well, it's not about length of life. It's about quality of life. Remember, these drugs improve symptoms and quality of life. So even if that's the topmost concern for your older, frail patient in clinic, these are data from the 2 newest pillars, ARNI and SGLT2 inhibitor. They make patients feel better, including among the subsets that are very old. Another key point to consider, though, is that among eligible patients, GDMT has a favorable safety and tolerability profile. And that's across the entire spectrum of age. Just breaking news, but high rates of adverse events happen to patients in heart failure trials, even the patients randomized to placebo. When you look at the objective data, and I'm not saying side effects can't happen, we've all seen it, but when you just take a step back and look at the data, The rates of side effects and adverse events in the GDMT arm and the placebo are essentially equivalent. In fact, there's fewer usually serious adverse events in the GDMT group compared with placebo, and there's no significant differences in drug discontinuation compared to placebo. So we need to try to disentangle what are true medication-related adverse events from just having signs, symptoms, and heart failure, not being so quick to always just blame the medication when these patients are an extreme risk patient population. Classic example, another earth-shattering revelation for people. Patients with heart failure and lots of comorbidities, they get urinary tract infections. And they get urinary tract infections whether or not you treat them with an SGLT2 inhibitor. I know it's in the FDA label as a caution and whatnot, but when you look at the objective clinical trial data, there is no consistent evidence that SGLT2 inhibitors increase the risk of urinary tract infection. I distinguish this from genital mycotic infections where there is a small increased absolute risk. But again, just because someone's had a urinary tract infection and they're 80 years old doesn't mean that we should withhold a medicine definitively proven to help them both live longer, but also importantly, feel better. Another point of hesitation, and I know I'm running short on time, but well, sounds great, but it's just too gosh darn expensive. And people point out when I get on the podium and I'll say, well, less than 1 in 10 U.S. patients with HFrEF discharged from the hospital are discharged on quadruple medical therapy. And they'll say, well, that's because these medicines are too expensive. You know, it's the drug companies and it's the insurance and everything. It's not my fault. Well, then I say, well, sure, we all have patients that barriers were cost and access. I see it in my clinic. It happens, right? But if we're going to blame that for the widespread systemic underuse of GDMT, why on earth are less than a third of our eligible patients getting even generic therapy with 3 drugs like ACE, beta blocker, and MRA? It was all about cost. Median out-of-pocket cost for a Medicare patient for 3 life-saving drugs, $160 for an entire year. Average cancer therapy that's newly approved, $283,000 per year. Yet, can you imagine if we said cancer patients, less than a third of them are going to get chemotherapy? Our society, our practice would never tolerate that. Yet that's exactly what happens with even generic GDMT for our heart failure patients, even though, again, their risks of death and morbidity are just as high as the average cancer patient. So last slide in summary, the grim reality is that less than 1 in 10 of our eligible HFrEF patients are prescribed quadruple medical therapy in the United States today. And that equates to many of our patients with heart failure unfortunately dying or being hospitalized every day without ever receiving medications proven to prevent these events, despite being eligible. We need to give our patients the opportunity, the chance to benefit from medications proven to be effective. We need to prescribe 4 pillars simultaneously or in rapid sequence to all eligible patients. Yes, there's no absolutes in life. Some patients may not tolerate this, but think of the alternative. Think of the risks of omission and consider that many more patients are not tolerating, quote unquote, the status quo approach where we do one move at a time, serial, slow, selective. And when I say they don't tolerate it, they're deaths or hospitalizations that could have been prevented if we did timely, upfront, rapid initiation of GDMT. So sorry for going a couple minutes over, but thanks very much for the attention.
At first, patient, our cardiologists always brought in patients with HFrEF or our hospital managing those folks.
So anecdotally at Duke Hospital, our HFrEF patients mostly get on cardiology services. Mostly. I know it's not generalizable to all centers and community versus academics and all sorts of things. HFpEF is much higher proportion on hospitalist services. I think that's changing. It comes down to bandwidth. I mean, historically, we were used to kind of have a nihilistic approach to HFpEF, thinking we didn't have much to offer, so you didn't necessarily need cardiology expertise. I think that's really changing now. But we're kind of stuck in the times where HFrEF does seem to be tracking more with cardiology taking care of them primarily. Thank you.
What are your thoughts on nurse-driven or clinician-driven approach to titrating those medications?
Central. It's critical. And we've had this at Duke only in the last year. even though we've been trying to get this, and you got to get, clinician buy-in and also hospital system buy-in and business people buy-in more than anything. But it's made such a difference. And there actually is really good data on this for actually improving GDMT utilization. I mean, again, I'm bashing my own specialty. I'm a doctor. I'll say doctors in general. I'm generalizing here. We overthink it. We are better off having people just follow algorithms that are dedicated and focusing on the medication themselves, including when the patients are feeling well. That's the key opportunity, when they're feeling well, to get these preventative therapies on board. And there's been multiple publications talking about pharmacists or nurse-driven protocols with an MD supervising, essentially. There's even a study for the Brigham and Women's Health System has done multiple studies where they have navigators, which essentially, we're talking to the investigators there, are just college kids, essentially, that are following an algorithm that when they have questions, they are, refer to a pharmacist or an MD, but they just follow the algorithm, make the calls to the patients, order the labs for the patients, and then it goes to an inbox that someone else reviews. But again, we need the bandwidth. It's an all hands on deck mentality. But that being said, people say, oh, I don't have the bandwidth for this in my center. Well, the easy step, though, you have a patient in front of you today. What do I need to do what's my algorithm for starting GDMT? Right, 4 clicks if they're not already on. Just 1, 2, 3, 4. Carvedilol 3.125, Entresto 2426, spironolactone 12.5, and empagliflozin 10 milligrams a day, or dapagliflozin or whatever. It's not that hard. Again, this is how we improve outcomes for these patients. That's the algorithm. Even if you kept people on low doses for the entire time, that's the first priority. That early separation of event curves, that's happening when they're on the low doses. That's the best bang for your buck. So even if you don't get the true gold medal by getting them on Carvedilol 25 BID, or Entresto 97-103, just think how much better off we would be, even if all our HFrEF patients that were eligible had at least the sprinkle mentality of at least low doses of all 4. We use combination medicines all the time, blood pressure pills, combo diabetic pills. There's no reason you can't do Carvedilol 3.125 and, spironolactone 12.5 and all this at the same day. The median blood pressure for a heart failure patient is 130 when they come into the hospital, for example, or in clinic. We can do this.
All right, thanks. So a couple years ago, there was a study published about a poly pill, and that was with coronary disease. Like, they put an aspirin and statin together, and it showed improved mortality. I don't know much about the details of the study. Any thought on applying that here? Because this is where I thought it'd be beneficial.
Absolutely. It's been talked about kind of behind the scenes for some time in the heart failure community. There is a small study led by investigators in Texas that's from UT Southwestern that's testing this in terms of feasibility, but it makes total sense because, again, don't get distracted with kind of like it's not that they're not important. Like, get distracted. Oh, we got to get them on Carvedilol 25 and the first priority is low doses of all 4 pillars. That's the evidence-based approach, to be totally honest. You get the sprinkle mentality, and a poly pill is right up that alley in terms of making things easier for the clinician, increasing for the patient. The bar is so low with what's happening with the status quo approach. Again, we can't even give our generic medicines, even in the VA, same data. There's no cost and access issues to the average VA patient, yet the rates are essentially the same. So a poly pill would be a great strategy. We can make it easy. Obviously, some of the drugs are still branded, so there's different logistics you have to work out getting a branded therapy to participate in a poly pill and everything. But for our generic medicines, it would be such a convenient thing if we get someone to fund it. All right. Thank you very much.